Welcome, everyone. I'm Genevieve Frazier with Rogers Behavioral Health, and joining me today is Dr. Julia Carbonella and Dr. Johanna Younce to provide insights into assessing, conceptualizing, and treating religious scrupulosity. Before we get started, I would like to go over a couple of housekeeping elements. The webinar is scheduled for 90 minutes, and in order to receive full CE credits, you must be logged on for the duration of the program. This will be tracked via Zoom login and logout records. A PDF of the PowerPoint, including references, will be available to you on your personal dashboard at ce-go.com. An email with a link to your dashboard will be sent to you shortly after the broadcast ends. In addition, a recording of this webinar will be available on Rogers' YouTube channel within the next day or two for you to rewatch. Our speakers will give a 70 to 75-minute presentation, and thereafter I will facilitate a Q&A session. If you would like to submit a question to our speakers, please use the Q&A tab on your taskbar, and we will address those questions at the end of the webinar. And finally, we have enabled closed captioning for this program. Now I'll turn it over to our presenters.
Hi, everyone. Welcome. Thanks for joining us today. Neither of us have any relevant disclosures. And these are our learning objectives for today. And here are the main aspects of scrupulosity that we'll be covering. And here are several of our presenter subjectivities that contribute to our lived experiences. So I'm Julia Carbonella. I'm a clinical supervisor and a licensed clinical psychologist. And on a personal level, my pronouns are she, her, and I'm a second-generation Asian American.
Hi, I'm Dr. Johanna Younce. I'm a clinical supervisor at a residential program at Rogers. My pronouns are she, her. I identify as white, cisgender woman, and I do have a Catholic upbringing that might be influencing my perspective on these pieces.
So in this first part, we are going to talk about how to understand and assess scrupulosity. So in a nutshell, one way of thinking about scrupulosity is seeing sin where there is none. So religious scrupulosity, which is our primary focus for today, involves excessive fear or concern related to doing the exact right thing in God's eyes and wanting to avoid feared consequences of not practicing religion perfectly or fear of sinning in some way. Whereas moral scrupulosity is not tied to a specific set of religious beliefs. It's more centered around societal or general moral fears like, am I a bad person or am I acting ethically? So in terms of OCD, as I'm sure many of you know, obsessions are unwanted thoughts or images or impulses that are intrusive and recurrent. So for scrupulous obsessions, this is not an exhaustive list, but this can look like excessive doubt over whether I've committed a sin. So if I find myself daydreaming while praying, I might be questioning, does that mean I'm going to go to hell? It could look like unwanted intrusive images, maybe that of the devil or a fear of being possessed. One might have thoughts of swearing at God, or maybe questioning whether God exists, or maybe being convinced that there is a God, but constantly thinking that God is angry at you. One might dwell on consequences of not praying just right. So maybe being convinced I'll cause something really terrible to happen to myself or a loved one. It could look like excessive guilt and a strong desire to make up for past sins, or perhaps being overly concerned with needing to try harder or to be better or to be more spiritual in some way. Compulsions are recurrent behaviors or mental acts performed with the main purpose of alleviating anxiety stemming from obsessions or to prevent feared consequences from happening. So that could look like seeking reassurance from a loved one or a religious leader over and over again to try and seek certainty. So wanting to check with someone, hey, is this thought sinful? Are you sure? How do you know? And what if it is? What does that mean? It could be avoiding symbols perceived as evil, like a pentagram or the colors red or black, unlucky numbers or evil music. And paradoxically, I might also avoid religious services. So I might associate church with being the place that triggers a lot of intrusive thoughts, or maybe it'll be worse if I make a mistake in church, so I won't go at all just to be safe. Compulsions could also include cleaning or washing rituals to atone for past sins or for bad thoughts. And oftentimes there are mental rituals that are involved too. So for example, repeating certain prayers to a specific number or until it feels just right, making pacts with God, or neutralizing by replacing a negative thought with a positive one right away. So these are some characteristics that might indicate a clinical level of scrupulosity. So like many other psychiatric conditions, looking at whether symptoms are time-consuming, distressing, and impairing to the individual's life. And spiritual interventions, like going to confession, do not help alleviate scrupulous OCD. It might help provide some temporary relief, but the distress and the worries are pervasive and return soon after. People with scrupulous OCD engage in religious rituals out of anxiety and fear, not due to enjoyment or pleasure, like in healthy religious practice. Another flag is that other symptoms of OCD are often co-occurring. So someone might have harm OCD or just right OCD that extends beyond just the theme of religion. And also looking at what the norms are within the person's religious group. So if someone's behaviors are in the extreme minority, that's another indication of clinical severity. Also, counterintuitively, scrupulous behavior interferes with religious practice. So obsessions and compulsions might actually get in the way of someone going to mass, for example. And patients with scrupulosity might have a very narrow focus or bias on certain aspects of their religion and become very focused on doing things perfectly rather than looking at the big picture or the general intent of a behavior. They might spend so much time on rituals that they cherry pick and neglect other aspects important to their faith, like doing good deeds. And finally, examining the function of scrupulous OCD. So if someone is performing compulsions motivated by the purpose of bringing down their anxiety or distress, it's just like other OCD subtypes, just manifesting in a different theme. So these are some questions that can help guide assessment and provide insight into whether someone is struggling with scrupulosity rather than healthy spiritual practices. So many of them correspond to the clinical characteristics I just mentioned. So just to highlight several important ones. So reflecting on whether about 85% of your religious community share the same beliefs and behaviors as you, that's usually a good benchmark to consider. And also to emphasize the piece about impairment. So asking the individual about how much time do your beliefs and rituals consume and how much do they bother you? So of note, about 90% of the general population experiences intrusive thoughts that are unpleasant, but ultimately harmless. So meanwhile, the difference is that those with OCD place a lot of importance on these thoughts and interpret them as meaningful or significant. And these are cognitive vulnerabilities underlying this that we'll touch on in a little bit, but they become very fused with these thoughts that cause a lot of anxiety and distress. And also with regard to functional impairment, thinking about, am I neglecting activities of daily life because of my fixation on religious issues? Are these religious ideals getting in the way of my interpersonal relationships, my ability to perform at work, my parenting, or even my ability to participate in and enjoy positive aspects of my religion? So those can be cause for concern.
Here's me. So how do we measure scrupulosity? Until recently, the Penn inventory of scrupulosity was pretty much the only self-report validated measure in the literature that was available. It is scored on 0 to 4 scale. There are 2 subscales, fear of sin and fear of God. The pious does assess the presence of religious or scrupulous thoughts. It doesn't super well get at severity, and it doesn't assess impairment. So it's not the best measure for diagnosis, for example. Additionally, I actually did my dissertation in part on the factor structure of the pious, and it's fine. It's not great. There are some psychometric things that just aren't like super ideal for the pious or the pious are. So we've got a newer, more promising kind of subscale in addition to the original DOCS or dimensional obsessive compulsive scale that was developed in 2021. That subscale does rate frequency, intensity, duration, etc. of scrupulous symptoms. It does still need, a lot more research to answer some questions about its psychometric properties, including, is it invariant between different religious groups? And how does it work between, the general population versus examining like clinical OCD populations? Additionally, both of these measures really are focused on religious scrupulosity, and we don't really have a great measure on secular moral scrupulosity. So that's still something that's needed.
Okay, so moving forward to common clinical features and comorbidity. So a little bit about the prevalence of scrupulous OCD. One study has found that over 20% of those who are treated for OCD endorse some type of religious scrupulosity symptoms, and rates are possibly underestimated. So people with scrupulosity might tend to see it as a religious problem and seek guidance from their pastor or family member rather than seek treatment from a mental health clinician. And almost a quarter of people with scrupulous OCD actually do not identify with any specific religious affiliation. More research is again needed to clarify the nature of secular moral scrupulosity and also to explore longitudinal effects, like whether this figure accurately captures people who maybe grew up in a certain religion, but now consider themselves agnostic or atheist or non-denominational. Scrupulous OCD is less common than other subtypes like contamination and checking or just right. There does seem to be a link with greater rates of obsessional symptoms. So perhaps this could be related through shared cognitive factors like beliefs about the importance of thoughts and the need to control intrusive thoughts. And it also seems to be a subtype that varies with the intensity of religious observance within a group. So, for example, in less secular societies like Saudi Arabia and Egypt, there have found to be higher rates of religious obsessions and compulsions compared with more secular cultures. More research needs to be done to determine any causal effects, but so far, scrupulosity has been linked with lower self-compassion, specifically the factors of self-judgment or having a critical self-view, isolation, and also over-identification, which refers to exaggerating or ignoring specific aspects of your feelings or your experience. It's also been associated with thought-action fusion. So thought-action fusion has 2 components. One is the belief that experiencing thoughts perceived as wrong or immoral have the same consequences as actually doing them, that they're equally as bad. And secondly, that having a thought about a particular event actually increases the likelihood of it happening. Scrupulosity has been associated with mental contamination, which is an internal sense of feeling distressed or feeling dirty, even without physical contact with a contaminant. And it also commonly occurs with symptoms of OCPD, which is obsessive compulsive personality disorder, schizotypal personality disorder, and perfectionism, and not surprisingly, also with greater depression and anxiety symptoms as well. So to briefly walk through the cognitive behavioral model of scrupulosity, oftentimes there's a foundation of personal religious beliefs and also cognitive vulnerability factors, like again, perfectionism, overestimation of threat, and inflated responsibility. And along with that, beliefs about the importance of thoughts plays a significant role in this predisposition. So many individuals with scrupulosity tend to endorse that thought action fusion that I just described. So when normative, spontaneous, intrusive thoughts occur, instead of brushing them off and saying, oh, that's weird, our minds can generate just such odd thoughts sometimes, and being able to easily move on like someone without OCD might do, people with scrupulosity are more likely to interpret these thoughts as meaningful and ascribe a lot of importance to them. So this can be the gateway to a lot of doubt about their religious obsessions, this extreme fear of sinning or of angering God, which naturally can cause the person a lot of anxiety and distress. So as a consequence, they then engage in compulsive rituals, and these can temporarily bring down their anxiety and distress, but in the long run just reinforces this hypervigilance to their intrusive thoughts and doubts. And then importantly, intolerance of uncertainty really perpetuates the cycle. So these individuals have a really hard time sitting with the uncertainty. They want to be 1000% certain that something negative won't happen, which then leads them to review and check their thoughts over and over and feeds back into their anxiety, and also encourages them to engage in these behaviors that might provide that sense of certainty and relief, at least in the short term. So reassurance seeking from others, I just need to hear that God's not mad at me, or I need to repeat this prayer 7 times just to make sure it feels right, and that'll mean I'm not a bad person, for example.
Okay, so what is the relationship with religiosity or strength of religious faith? So, strong religious convictions, importantly, do not cause scrupulous OCD, and that's probably the most important point here. Now, high levels of scrupulosity are more common, like we said, in traditional or more religious versus less traditional societies. This is likely because OCD targets the things that we value the most, right? And so if you're in a community where everyone is very religious and religion is very important to you, that's what OCD is going to glom onto, because that's what can get you to be afraid related to. Religious identity or affiliation also does not predict severity of scrupulous OCD, but it does shape how symptoms manifest. We'll talk about this more later, but just for a short example, Catholic customs might facilitate excessive prayer, confessing to priests on a daily basis, reassurance seeking, and things like that. Whereas Jewish customs are very focused on behavioral rules and codes. So they might have more compulsions around purity rituals and adhering to diet codes. Driving home the point further, OCD symptom severity is actually negatively related to scrupulosity. So we find that aspects of spirituality, healthy spirituality, actually helps buffer OCD's impact on mental health. So it's kind of the opposite of making it worse, right? Shams and Milosevic said it well. Instead of being a determinant of the disorder, religion appears to be just another area where OCD expresses itself.
So what are some implications for treatment from the research to date? So individuals with scrupulous OCD have been found to have lower insight and more rigidity, especially those with greater symptom severity. This population tends to be less likely to seek medication, maybe again because they see it as more of a religious problem and not one solved by psychopharmacology, or it might directly conflict with religious beliefs or norms. And there's also evidence that scrupulosity might be associated with worse treatment outcomes. So a few hypotheses about why that might be. One is that maybe clinicians as a whole are less familiar with treating this subtype of OCD. Some might think, oh, I don't have experience with a particular religion, or I don't feel comfortable reaching out to collaborate with a religious leader the same way I might consult with a patient's parent or a spouse. Scrupulosity might be perceived as less straightforward compared to more common OCD subtypes like contamination or checking. It could be the case that patients themselves are less willing to challenge religious beliefs. They might be so fused with the sense of morality or feared consequences from God that they might not be as motivated to try exposures that just feel extremely wrong or blasphemous. And for some patients, it might also be hard to come up with or to land on exposures that provide hard evidence that just confirms their beliefs. And sometimes it'll be more about challenging and expanding that tolerance of uncertainty rather than a specific feared consequence. And also to the aspect of accommodation, friends and family with shared religious beliefs might encourage or enable compulsive behaviors. They might view them as devotional or morally upstanding or something to even aspire to, which unfortunately just perpetuates the OCD cycle.
So let's talk about navigating exposure treatment for scrupulosity. So just like with any other symptom theme of OCD, ERP is going to be the gold standard for treatment here. I'm going to really briefly go over what ERP looks like as a little refresher. So first, obviously, we're going to have that exposure to whatever their obsessional content is and or any feared stimuli. We're then going to prevent the typical compulsions or safety behaviors that the patient typically engages in to reduce that anxiety. So I have a scene here from The Good Place. This character, Chidi, is a person who is just paralyzed by any decision-making due to concerns about its moral implications. And so there's this scene where he says he doesn't want to sit in a chair because he didn't want to offend her in case she had a favorite. So if a patient's coming to my office and says this, I'm going to ask them, okay, in the next 5 seconds, I want you to choose a chair, sit in it, and I want you to sit with the uncertainty that maybe it wasn't my favorite chair that you chose, maybe it did offend me, and maybe that means something about you as a person. And we're going to continue with that at least until expectancy violation occurs. So whatever they were expecting to happen, God striking them down or whatever it might be, till that violation of that expectancy occurs, or habituation, if that's the model that you're going with. And then we're going to repeat that exposure over and over again until that learning is consolidated. So here's a much simplified version of the CBT model that Dr. Carbonella went over. So we've got the obsession that creates anxiety for us. So then we do a compulsion and get that temporary relief of anxiety. When we go through this OCD cycle, though, what are we learning? Well, we're learning that we cannot tolerate the anxiety. And our fears are being reinforced. We're thinking, well, I was safe at the end, or things turned out okay, but it was only because of that compulsion. It wasn't because the actual situation was all right. And so what we're going to do to try and actually learn something new is we're going to prevent that compulsion. So we're still going to have our intrusive thoughts or obsessions. We're still going to experience anxiety because of those things, but what we can control is our behavior. And so instead of doing our compulsion, we're going to instead just sit there, do nothing, and we're going to learn that tolerance. And so then we're able to learn that, oh, you know what, I actually can tolerate anxiety. And often we learn that that feared outcome didn't happen, and we're able to, over time, kind of disconfirm that initial belief. So for ERP, for scrupulosity specifically, when I'm talking to the person about their core fears, and I'm doing that downward arrow of, okay, well, why is that so bad? Why is that so scary? It usually gets down to one of these two things. It's usually, I will go to hell, and or I'm just like inherently a bad person. And so we want to use both in vivo and imaginal exposures, because there's going to be things that we're not able to necessarily disconfirm in the moment, right? You don't find out until after you die whether or not you're going to hell. So we're going to do imaginal exposures about that. Very frequently, I do the detailed worry scripts about going to hell as one of someone's exposures. An in vivo example might be writing a prayer wrong. We can go over some more potential exposure examples later as well. It's important to note that, like we mentioned earlier, some of these exposures can be uncomfortable for the therapist to ask the patient to do. And we may be reticent to kind of push patients far enough, but it's important to recognize that that might be one of the reasons why there are poor outcomes for scrupulosity treatment. So we got to find a way to work through that. And we'll talk about that in a little bit. So in functional assessment of OCD, just like any other OCD theme, we're going to need to identify those antecedents and consequences of our target behaviors. So what situations trigger intrusive thoughts or anxiety? What are that person's interpretation of the thoughts, and what emotions are resulting? Usually it's anxiety and or guilt. And then what are those compulsions that we're doing to try and respond to the intrusive thoughts and decrease our anxiety? Make sure not to forget about mental compulsions as well. And a lot of times we need to also ask patients, what are the situations that we avoid due to obsessions? Whenever somebody comes in and they're saying, you know, I don't really get a ton of anxiety right now, then either I'm thinking, okay, either you don't need to be here, or you are doing a really good job of completely avoiding your triggers so that you don't get anxious. So then I want to ask, what are those situations that we're avoiding? So I'm going to go into a little bit more detail on the following treatment considerations. So we want to work on engaging clients in treatment. We want to work on that therapist, our own hesitancy potentially to go far enough with ERP, as well as balancing where's that line that we shouldn't be crossing in exposures. We want to make sure we're addressing mental compulsions and knowing how to do that. And we'll talk about consulting with spiritual resources. So when we engage clients in treatment, patients are often worried when going into treatment that you don't value their religion. So we need to be extra clear that the goal of treatment is not to become less religious. It's actually the opposite. We want to help you return to a healthy, authentic relationship with God, your religion, values. Right now, you're doing these prayers and rituals from a place of fear, right? Not a place of peace or joy. You're praying to get rid of your anxiety, not to build your relationship with God, not to praise God, not to give thanks, a lot of the typical reasons for prayer. Additionally, I often explain that OCD is basically the antithesis of faith. OCD requires absolute, without a shadow of a sliver of a doubt, certainty. And if that certainty was possible, faith would not be necessary, right? And so faith requires us to be able to experience some amount of uncertainty, and because that's where faith comes in, right? So I want my patients to learn to truly trust their God and build their faith by challenging their OCD. When discussing this with a past patient of mine, he reflected that it was kind of like putting prayer coins in and getting out reassurance, almost like a coin machine. And he was reflecting that, his OCD had really twisted his relationship with God to be transactional. And that in Christianity, which was his religious affiliation, is not the goal at all. Adding on to that, we need to make sure we're demonstrating cultural humility. Patients aren't going to want to work with you if you don't fully respect their religious beliefs. And we need to make sure we're not trying to convince them that their religion is wrong. In fact, if anything, I might use their religion or scripture to help convince them that their OCD is wrong when that's appropriate. And we can use Socratic dialogue when patients have some poor insight. So again, sometimes patients with moral religious scrupulosity might be more reticent to take that risk that we're asking them to take with exposures. So they might need some help understanding that, their behaviors might be excessive. And we can help them do that often through kind of some of that Socratic dialogue. One of the things that I might ask is, I'll ask them to identify who's someone in your faith community that you look up to. And then I might ask them, does that person do these same things? Is that person spending their entire day repeating prayers at the expense of other things? And if they're not, well, why don't we try to exemplify them more rather than just doing these things because you're afraid? And last, I might ask, is this really the life that your God wants for you? There's a portion from Proverbs that is stated in Jewish ceremonies that says the Torah's ways are pleasant ways. So if you're killing yourself to ensure that all of your meals are kosher at the expense of everything else, that doesn't sound like pleasant ways to me, right? So maybe this isn't actually what your religion requires of you. And when all else fails, using a little creative hopelessness. I like to borrow from ACT in my ERP work. So I might be asking that person, how has what you've been doing working for you? Okay, so attempts to control, rationalize, or suppress your intrusive thoughts have not worked. Otherwise, you wouldn't be here. So instead of trying to do that harder, let's try something different, something new. Talking about therapist hesitancy to go far enough with ERP. Evidence shows us that we really need to make sure we're going all the way to the top of a patient's hierarchy in order to provide the best outcomes for treatment. We need to address that worst fear. And if we do not, OCD will keep a handhold on the patient, and it can increase the risk for relapse, right? Because we've learned that, okay, I can handle this, like I can do all these things, but not that though. Or, I can do all these things, but only in these situations. And when we're putting those limitations on the learning that we're trying to be getting from exposure therapy, that again, that's where OCD keeps its claws in you so that it can then build and really come back in full force later on. And, it's important to remember that just because the theme is religious or moral does not mean that we don't push the envelope with our exposures. Part of our comfort with pushing that envelope is going to be being able to actually understand the true line between right and wrong in that patient's belief system, not OCD's line. And that can be helped a lot by consulting with clergy on this, which we'll talk about again in a little bit. So where is the ethical line that should not be crossed? Well, we don't ask clients to flagrantly violate religious laws. We can ask them to temporarily stop doing things that are not strictly required by their religion. Most Christians, for example, while it's definitely recommended to pray every day, it is not a requirement. If somebody doesn't pray for an entire day or even a few days, that's not like against their religion. And so we might ask them to stop doing that for a period of time or to reduce it significantly for a period of time. Again, going back to you're doing this for unhealthy, unhelpful reasons. So we're going to have you stop doing this compulsive behavior of this compulsive prayer so that we can get you to a point where you're able to pray and get back to that in a healthy way. We can also ask clients to do things right up to the line of what's right and wrong. So it might be things that most people in their religion would not intentionally do, but would not violate religious laws or values. So things that like feel like they'd be wrong, but aren't. An example of this was I had a patient who was very concerned about touching any kind of religious objects if his hands were not completely clean or if he felt clean. So what we asked him to do was he had a dog, right? So pick up dog poop outside after your dog goes to the bathroom. Obviously not with your bare hands, do it your normal way with the dog bag and everything. And then I want you to immediately go inside and I want you to touch a crucifix all over. Now, could it be that that person had just a little bit of poop on their hands and they didn't realize it? Yeah, that's possible. And do people go outside and do things and not wash their hands every time before they touch a crucifix? Yes, they might just not like intentionally do things in that order for any specific reason, right? So we still need overcorrection. The focus is on tolerating religious uncertainty of whether it's wrong, not doing things that are actually violations. Again, we're always going to want to be focusing on that uncertainty piece of it. So again, we wouldn't do an exposure to grope a stranger, right, for someone with sexual obsessions, but we would do an exposure to walk by a stranger with your arms loose at your sides, thinking, maybe you will, maybe you'll lose control and do that, right? So it's just the same thing with religious OCD. We're not going to ask them to actually do things that would be considered wrong. We will ask them to do things that create that uncertainty. We're going to keep that at an acceptable level of risk for them, and doing things that their religion says will, for example, like lead to them going to hell or God condemning them. That's not an acceptable level of risk, so we're not going to ask them to do that. Mental rituals are very common in scrupulous OCD, in all types of OCD, but I think it's one place where we really need to make sure we are aware of them and asking about them. So Dr. Carbonella mentioned a few of these, but briefly, mental reviewing situations to reassure yourself that you did nothing wrong. is often a common one. Attempts to suppress blasphemous or other intrusive thoughts they consider wrong can be considered compulsive behavior. And neutralizing a negative thought with an intentional positive thought, like feeling like you have to undo it. So it's really, really important for us to explain to our patients that thought suppression does not work. If you've treated OCD for a while, you'll probably recognize the white bear study that was conducted in 1987 by Wagner and colleagues. This was a study that I explained to my supervisees and patients all the time. So they asked people, one group of people were asked to, for like 5 minutes, try not to think about a white bear, but every time you do, mark it down. And then another group was asked, okay, in the next 5 minutes, same amount of time, I want you to just mark down how many times you thought of a white bear, right? So both groups were introduced to the idea of a white bear. Only one group was asked to suppress that thought. On average, the group that was asked to suppress the thought about the white bear more, right? So this is just how people function and how thoughts work. So we're not going to be able to get around it just because we want to suppress the thoughts really, really badly, right? If anything, that's going to make them come up even more than they otherwise would. And so we need to help explain to the person, like, this isn't going to work. So again, let's try something different. One thing that is often tricky for folks when it comes to mental rituals is that they often are so automatic that it's difficult for patients, even if they want to, just not do them. So I think of it very similar to automatic thoughts, like we would think about with cognitive restructuring work. So instead of just resisting these compulsions, we might need to start with undoing. So if, for example, I have a patient who automatically tells themselves when they're concerned or when they have an intrusive thought about like whether or not they love God enough, they might have a ritual of thinking to themselves, I know I love God. I know I love God, right? Providing that mental self-assurance. I'm going to ask them to, once they notice themselves doing that mental ritual, I want them to think to themselves something like, I can't be sure that I truly love God enough. So we want to move them back to a place of uncertainty from this ritual, which is trying to give them certainty about them loving God and knowing that they love God. Because you can't know, not 100%, not to the amount that OCD wants us to. So eventually, if they do that enough, where we're moving back towards the uncertainty thought that maybe not response, we're going to be, the mental compulsion itself will start to become less automatic, and eventually that person will be able to truly do nothing in response to intrusions. But that's typically where I start. Let's talk about consulting with spiritual leaders. So clients do typically turn to spiritual healers or leaders first when it comes to scrupulous OCD. And so it can be really, really beneficial for us to interface with the spiritual leaders around us. It assists also in engaging the patient in treatment. They're going to know that you value their religion if you're actively consulting with their religious leaders, right? Got to remember to continue to be respectful of religion when talking to the leaders. Most will work with you, even if you're not of their religion, as long as you are respectful and show that you have, knowledge on the problem that the person is coming to you with. We can use spiritual leaders as a resource also for helping differentiate religious requirements from scrupulosity. The patient is going to typically have the most strict perspective and might be not able to accept flexibility in religious law if it does exist. And so in order to learn the true line between right and wrong in that person's context, we can ask their spiritual leaders, and they're often going to be able to tell us that answer. They can also assist with assessment, especially if we're really unfamiliar with the kind of community that the person is coming from. Those within a particular religious community are going to be best equipped to identify what's outside the norm. And so they're going to be able to tell us, you know, that is actually something that we do, right? Whereas if I had to guess, I might have guessed that it was OCD, right? And so it's able to help us to understand that so that we can have more confidence in our treatment. We can also help them. What I see in the literature that has examined clergy members' responses and perspectives on scrupulous OCD folks is that they want to help, but often don't exactly know how and might be concerned that they might make it worse somehow, right? And so we can also help to provide them education on OCD and how to support their lay folks, their flock from an OCD lens. And so one thing that's important to note, research has kind of shown that more conservative clergy might be more likely to respond to the patient in ways that are inconsistent with ERP. So example, telling them that maybe they should be confessing their intrusive thoughts and things like that. And so if we are able to give them education like on OCD, the nature of intrusive thoughts, the fact that confessing is going to make their thoughts like come back and be worse, they can potentially then understand that and then work with us and work with the patients more effectively. We can also give them information about how to support patients without giving reassurance. Some of the things I would suggest might be, you know, encouraging the client, instead of praying for their anxiety to go away, to pray for grace and the strength to accept and move on from their intrusive thoughts without compulsions. They can also help us in communicating the difference between healthy religious practice and scrupulosity. We have a really great chaplain at Rogers who I work with frequently, and they do such a good job of talking about that piece I mentioned earlier of like, is this coming from a place of fear or is this coming from a place of peace? And are really great at articulating that. It just means something different coming from like a chaplain or a spiritual leader perspective. And they can help encourage a return to faith and examining with the patient like what faith means, and remembering that faith is not OCD. So with our powers combined, you know, we can really make a difference in clients' lives. I wanted to talk about a few kind of common presentations that we see in some of the more common religious groups in the US. So for Judaism, some really common concerns are going to be, for example, over concern about kosher laws. And this is despite some flexibilities in the laws, including Biddle and Rove. And both of those they apply in very specific situations, but they do say that, for example, you can have a drop of a forbidden food if the rest of the meal, I think like a certain percentage of the rest of the meal is still kosher, right? And like if something is like accidentally added and it's just a certain amount and you didn't realize it, like that's okay, basically. So they might be overly concerned and trying to ensure like complete perfection about those laws. This picture here shows a man who is wearing tefillin. So that's the wraps around the arm and then around the head and the box. at the front of the head. They are supposed to be positioned in a very specific way, but they sometimes get like really focused on that, right? So they might be adjusting and readjusting their tefillin before prayer. The Shema is a specific prayer that if you say it, you're supposed to say it with like a certain focus. So naturally people with OCD can get stuck on that, and the idea that they have to have a perfect focus, so they'll repeat it over and over again in order to get that perfect focus. Keeping Shabbat laws is also very common. So there are lots of laws about making sure that they're not doing work. There are even laws related to like not turning on or off lights or closing a circuit, I believe is what it's mostly around. So there's concerns about that. Repeating or restarting purity rituals. So there are washing rituals that are done in Judaism. And there's often people who maybe doubt about whether one might have become unclean after washing and feel like they need to wash again. Vows and concerns about honesty are relatively common. They might avoid committing to anything and be very careful about their language so that they ensure that they're not going to break their vow. And a very common one, especially in more Orthodox religious communities, over asking halakhic or law related questions to the rabbi. So that reassurance seeking of like, is this okay? In Christianity, so this is a picture of a Catholic confessional booth. So that's one thing in the middle there. Over confessing to priests is common. There's also concerns about one's commitment to God. So the idea or the concern that do I love God enough can be very amorphous and uncertain. And so people often get concerned about that. Concerns about sexual purity are very common, including just normal, uncontrollable sexual feelings they might interpret as wrong and be concerned about that. Constantly praying for forgiveness for potential sins, doubt about whether one might have sinned. Reading Bible passages for reassurance, or for trying to figure out an answer to some theological question. Avoiding the number 666 or images of the devil. Fear one might accidentally let a demon into oneself. So what if I, what if I somehow had the thought that like I'm inviting a demon in and then it happens? And I've also heard fear of one is secretly the Antichrist somehow. In Islam, very commonly, there are a lot of like washing rituals in Islam. So there's wudu, which is like a daily one. And they are supposed to do that before prayer. They might be repeating those rituals over and over again to make sure that they did it correctly. A lot of times when it comes to folks with scrupulous OCD in Islam, it can look more like contamination OCD. So we need to like be aware of that and ask like, what are you washing? Like, are you washing because you are contaminated, or are you washing because you are doing wudu? To see what the kind of core is behind that. Concern about becoming unclean after wudu, maybe while praying. So for example, like you become unclean if like you urinate. So men might be concerned, like, what if a small drop of urine comes out of my penis and now I'm unclean and I'm praying and that's wrong. I need to redo it. I need to undo it. Concern about intrusive doubts about, one's faith or beliefs. Doubt about fasting appropriately during Ramadan. I've heard of someone being concerned about swallowing saliva, which is not against the rules during Ramadan, but concerned that that was breaking their fast. Reassurance seeking also with imams or Muslim scholars. And there can also be intrusive thoughts of Dajjal, who's kind of an evil creature, kind of similar to the Antichrist, if you're familiar to that concept in Christianity. So one thing that I also note to patients is that ERP is not inconsistent with religious teachings. And in fact, there are teachings in each of these religions that basically are very similar to ERP. So this first quote is from the Mishnah, and it's about a Jewish requirement to ensure there's no bread in the home before Passover. And it is distinctly saying, like, you do not need to be concerned that, oh, maybe a rat dragged leaven from one house to another. It's saying that in that case, if you're going to be concerned about possibilities like that, there's going to be no end to the matter, and it would be impossible to rely on any search for leaven, right? So it's saying specifically that you do not need to have complete and utter certainty. There is a old Jewish scholar called Maimonides. He talks about overcorrection, essentially, in one of his writings. One small quote from that: temperaments should be treated in this manner. If one was far over to one extreme, one should move oneself to the other extreme. Then he talks about how and eventually be able to get back into the middle, right? So back to that uncertainty. The Christian belief that Jesus is the Son of God and Christianity died for all of our sins as humanity, that fully implies that God does not expect perfection from humans. And if perfection was possible, we would have no need for God and for Jesus. There's lots of people in Christianity and Catholicism who wrote on scrupulosity. This priest, Father William Doyle, in the 1800s wrote, "It is a fundamental truth that we cannot love God unless we believe in his love for us. Scrupulosity completely represses such a belief and thus paralyzes all generous effort." So again, scrupulosity is not religion. It is something that kind of goes against and is antithesis to faith. And then in Islam, there's actually a concept called waswas, and it has been recognized in Islam since its conception. It means overwhelming whispers in Arabic, and it's basically the idea of, intrusive doubts. There is this hadith that frequently is elaborated on by imams and scholars when discussing waswas. And it is that Allah has forgiven my ummah, my people, for the thoughts that come to their minds unless they act upon them or utter them. So truthfully saying, like, random intrusive thoughts, we do not have to worry about those.
So here's a case example to help illustrate some of these principles that we talked about in terms of conceptualization and treatment. So using the addressing framework, this patient is a 34-year-old, diagnoses of OCD and unspecified depression, no physical disabilities. He's a conservative, white, Jewish man, middle-class SES, heterosexual and married without any indigenous heritage, an American citizen, and a cisgender man. So for some background context, Jacob had always been very conscientious, and this was reinforced during his childhood, and he was praised for being religious and very well behaved. His family of origin was Jewish, but then after getting married and having a child, he became even more conservative in his faith. And he also became increasingly fixated on being a good person, being a good role model, and being a good father. So this manifested in spending more and more time with washing rituals, repeating religious passages until he felt he had done it with complete focus, and then also seeking out more religious reassurance from his rabbi. So his rabbi eventually recommended that he should look into mental health treatment for these increasing symptoms. So upon intake, this patient's score on the Y box was 22, indicating on the higher end of the moderate severity range. And altogether, he was spending around 3 hours each day performing these compulsions. And a functional assessment helped identify and also for the patient to increase awareness of his individual pattern of symptoms, such as his fear cues of excessive doubt about doing rituals correctly and following religious laws precisely, the feared consequences, again, of being a bad person or condemning himself or his child, and then also the compulsive behaviors of excessive reassurance seeking, repeating, mental checking, and eventually avoiding synagogue as well. Jacob's rabbi was consulted and some psychoeducation was provided as well to just help support with reducing accommodation with providing reassurance, even when it's well-intentioned. The initial exposure hierarchy was also discussed to confirm that they were on the same page in terms of not directly violating any Jewish practices. And the rabbi was also consulted and brought on board for the patient's shared goal to be able to return to synagogue with his family and also to participate in religious practices, again, out of enjoyment and community, not despite, because of fear or anxiety stemming from the religious obsessions.
So in treatment, we developed a exposure hierarchy of about 48 items. So here are some examples of things. So saying just exposure to just like intrusive thought, I may be condemned by God. Praying the Shema once, not repeating or using mental review to examine his focus, praying the Shema incorrectly or incompletely, just to practice doing that on purpose, see that it's not terrible, or for only a certain amount of minutes a day. So kind of working on reducing some of the repetition. Writing a worst case scenario of being a bad father and role model, since that seemed to be at part of the core of this, we wanted to make sure we were targeting that as well. Saying or writing, I might have not done rituals perfectly today and God might be displeased. So just exposing oneself to that uncertainty phrase. Reading examples and stories of others who have violated religious doctrines, right? So facing, yeah, there are people that do this. You could do it. It could be. Looking at a video or photo of non-kosher food. So the best example of that is like a bacon cheeseburger from McDonald's. Looking at a picture of a bacon cheeseburger next to a photo of one's son. So thinking about, yeah, those two things, those two kind of fears and concerns, maybe even going to thinking about his son eating a bacon cheeseburger. And since he was avoidant of synagogue, we wanted to work him towards going back to synagogue. So it started with looking at a photo of his temple, walking by the temple, and then moving to attending religious services for 10 minutes and then attending a full service with his family. Another option as far as like kosher concerns, using a clean spoon that was designated for meat, but was clean, to put flour into cake batter that has milk as another ingredient. So again, trying to find these ways that we're going right up to that line where it kind of feels wrong, but it isn't. And then working on ritual prevention. So, we made sure that he tracked his compulsions daily. That was in part to increase awareness of how many times he was actually like repeating the Shema and other things. Limiting reassurance seeking from a rabbi or his wife to 1 time a day. He'd been doing it very, very frequently. He didn't get a hold of one, he would usually talk to the other. And so working with both the rabbi and wife to say, nope, we're not going to give you any more reassurance. You already got your one. So that's kind of how we started out in the event, then eventually moved to no reassurance. Performing religious rituals 1 time a day at most, and then sometimes performing it incompletely or incorrectly, and just allowing, that to happen. Interrupting any mental review with a timer. Again, this was to start out. He wasn't always willing to go all the way with completely preventing rituals. So sometimes we compromised for a short period of time on, okay, so why don't we have, instead of you mentally reviewing for an entire hour, why don't you do it for only 30 minutes? And then why don't you only do it for 15 before we brought it back down to not mental reviewing. And then again, in a similar way, starting with delaying time between that urge to rewash or do that washing ritual and actually washing. This is important too, because it's not needed that they're constantly kind of ritually clean. And so making sure that like he was only doing that in appropriate times. And undoing compulsions by adding something like, I can't be certain, or I may still be condemned if he's got those mental compulsions. So we started with, again, that psychoeducation, consulting with rabbi, tracking those compulsions to increase awareness. We also worked on identifying values. I think sometimes when it comes to scrupulous OCD, the patient does get, like we mentioned, really, really focused in on minute details of their religion and really lose the big picture. And so by talking about values, sometimes we can get back to, okay, what is the actual big picture? And that can be a reminder of, okay, am I getting lost in the trees and missing the forest, right? And then also using a bit of motivational interviewing to increase the engagement in ERP based off of what he was saying that his values really were. We always collaborate on what exposures to start with. We try and start with around a 3 or 4 out of 7 for anxiety level. He engaged in exposures at minimum once a day. If they were shorter exposures, then we would make sure he's doing repeated trials. And then moving on from exposures when we're seeing that kind of decreased anxiety, so a bit of habituation, and when he's saying that that safety learning is consolidated, like I do feel like I'm not as concerned about this, and I feel like it's not as dangerous as maybe I thought that it was. And then really emphasizing that response prevention, just with the level of different types of compulsions that he was doing, just wanted to be working on just really scaling that back. And then continuing on through the hierarchy with increased difficulty. And then finally, we worked with him on relapse prevention, which often for me includes having that approach attitude towards anxiety and religious uncertainty, rather than the avoidance orientation that we had before, right? So finding ways to be uncertain and then refocusing from wanting certainty to embracing the opportunity to express your faith. So yeah.
Thank you very much. And now we will go into our moderated Q&A portion of the webinar. Again, if you do have a question for our presenters, please use the Q&A tab at the bottom of your Zoom screen. And I will be grouping questions together. We've had a lot coming in, and so I'll group things together and run through as many as we can with the time left. And if we don't get to your question, you can always submit a follow-up to us at webinars@rogersbh.org, and we can follow up with you from there. So first question was around the assessments used at the beginning and also children. So can you use those assessments on children, or at what age would you assess for religious scrupulosity, and what would that process look like?
So I can take this. I personally don't work a ton with children, so that's a really great question. I don't know if either of those measures have been tested much with children. The research that I know of has focused on adults. So I think that would be a great area for further research. I will say that even though it doesn't have like a scrupulosity specific measure as part of it, the CY box, the Y box for children, can still capture scrupulous OCD, as long as you're giving that to them, and they know, what they're supposed to be, thinking about when they are filling that out. So that's probably what I would use for children, just because that's where what's actually been validated.
Yeah, I agree. I've used the side box before as a starting point, and have done kind of like a semi-structured interview to clarify some of the nature of obsessions from there.
Yeah. Several questions and comments around consulting with religious authorities, clergy members. One question: how would you work with an authority in the religion who does not understand the goal of ERP, or does not heed the advice regarding reassurance seeking, excessive religious behaviors? Or how would you work with a religious individual leader who doesn't seem bought into the treatment model of the patient?
Yeah, so that gets really challenging, right? It happens. What I would say is kind of just like with our patients, do what you can, like what you're in control over. So I would still work with them, helping them to understand. I think it could be helpful for you to potentially come back to them with some understanding of, maybe some writings from people in their same religion who've talked about moral scrupulosity, like almost providing them those resources. And I actually have some at the end that we'll talk about here. Sometimes that could potentially get them back around, but then it's also just helping, like doing your best to provide the education that you can, and then knowing that we can't control like what that person does. And so if they're not willing to, for example, stop giving reassurance, then we're just going to go back to our patient and we're going to have them work on, the thing that they should be responsible for anyway, really, which is working on stopping themselves from asking for reassurance. So I would just do what we can to try and provide that education, to try and help that person, the clergy get bought in. And then if that fails, just do our best to work with our patient, potentially without the continued support.
And on that note, what is the best way to outreach either a religious figure or priest, rabbi? Like, what process do you go through as a provider?
Yeah, so I think a lot of times the patient has already been talking to somebody, not always, but usually that's the person that we would want. So, the normal process of getting an ROI for the religious leader, setting up a meeting with them. Part of their job is like meeting with they're the people in their religious community, and so they should have, be able to make some time for you. And then, just discussing it with them, making sure that you're showing that you value their opinion and their perspective on the case, and like getting more information. And so, usually it's kind of like setting up like an appointment. I would typically do it over, Teams or Zoom, or just a phone call. And that's a great way to kind of start that relationship. I would usually identify like an individual that's most related to the patient's life and religion, and then I would, find a way to reach out to them directly.
And just to add, another consideration is to also just collaborate with the patient to see, sometimes they would rather you set up a meeting and speak to their religious leader separately. They don't necessarily want to be involved in that conversation. Other patients really prefer to have a shared meeting and to have a space to kind of share their perspective and all talk together. So that's an individual preference as well.
Great. Several questions about Buddhism, Taoism, Hinduism. Like, where do people get more information about rituals and that education? Where can they do a deeper dive?
That's an excellent question. There isn't much out there for scrupulosity, at least. But that's not to say that it doesn't happen, because again, anytime that we care about things, OCD is gonna try and target it. I would suggest, just doing your best to find out more about it in general, just like the religion in general. I would say that we really do need more resources on people from those religions, especially religions that don't necessarily have like a single deity, because things can get, I'm sure, very different.
There were a couple of questions around co-occurring conditions, autism, major mental illness, schizophrenia. Like, how do you tease those pieces out? What do you treat first? How do you approach this treatment differently based on that?
I think it's the same as, any patient that has co-occurring diagnoses. A lot of times it comes down to what is causing them the most impairment, and honing in on that first. So a very thorough differential diagnosis, maybe collecting some collateral information from family members or partners to really figure out what to first target. So it might be the case that even if scrupulosity is present, it might not necessarily make sense or be in the patient's best interest to dive into ERP. It might make more sense to look at suppression and see if once that kind of alleviates and they're more activated behaviorally, whether symptoms might decrease in terms of OCD. So maybe not satisfying, but I would say it depends on what is kind of more acute and what we could create more change in first.
Yeah, I will add to that. I think one thing that can be challenging that I see from time to time is the combination of and teasing out scrupulosity versus like a psychosis. So I have had a patient who was concerned, had a previous concern that there's a demon that was physically like attached to his head. So had kind of sensory almost focus, somatic hallucinations regarding that, and then also that kind of belief that there was something attached. This was outside of the norm of his religious context. And yeah, and so that can be hard to differentiate, like, okay, is this person's beliefs extreme because they're concerned that it might be the case, or are they very much convinced and saying that no, they physically feel, something. You have to have a good understanding, I think, of like what hallucinations are. And ultimately, everything's uncertain. We could be wrong, and we'll try and treat what we can. And a lot of times, if like one of the things gets better, like if they do have both, for example, which this patient did, sometimes if one of the things get better, then the other problem rises up more. And so we're able to kind of work on that differentiation. But I think that the biggest key whenever it comes to diagnosis and like figuring out like which symptom belongs to which disorder, we're always going to also be thinking about that cultural piece and whether or not this is truly outside of the norm for them, and in what flavor it is. Getting a sense of, is it a psychosis flavor, or is this a scrupulosity, like you're doing this out of fear kind of flavor. And I think the more that you work with one or both of those conditions, the more that becomes kind of apparent to you. But either way, no matter what it is, we have to be able to recognize whether this just feels strange to us or whether it is something that is outside of their own context. Yeah.
Thank you. What are the unique challenges to clients that are not religious? They may not have religious peers to compare themselves to, for example. They may not have religious laws or rituals that they participate in.
Yeah, I think a lot of that is, again, just doing a thorough assessment of whether their fears are ego-syntonic or dystonic, whether it really aligns with their values and beliefs, or whether they're really bothersome and distressing. So I think a lot of the work there is conceptualizing that and then also going after that uncertainty. So whatever thoughts or experiences kind of underlie or provoke that unsettling feeling of discomfort, whether that looks like I'm a bad person or I'm going to be labeled as like a sinner forever. Doesn't totally matter the content as long as they are feeling that negative experience and then being able to tolerate that uncertainty, the fact that they will never know for certain whether that's true or not.
Yeah, I totally agree. Focusing on that uncertainty regardless. I think a lot of these things we talked about today still apply to secular moral scrupulosity. I think it's just, again, like you said, it's just a little harder because there isn't necessarily something definitive, right, that we can go back to that says, oh, okay, well, I know that this isn't considered wrong in your religion because it's more of their individual morality. But like we can still ask them, who is someone that you look up to, who you would consider a very moral person? Are they doing these things? Okay, maybe we're doing things a little bit more excessive than we need to. And so using more of the motivational interviewing and curiosity to find out what they actually believe, instead of, being able to use some kind of external source for that. Another test that I haven't used, but I've seen it in the literature, is the gun test. So people have said, okay, if someone put a gun to your head and you had to decide if this was moral or immoral, like what would, and if you were wrong, you would die, like what would you say? And it sounds like a lot of the times people will go with, the kind of more reasonable answer because they know on some level that they are being excessive with their behaviors or their thinking. So you could try it. Let me know how it works.
There are so many questions coming in, and I know that we only have a couple of minutes left, but one theme that is coming up is how would you navigate working with somebody who is in a religious cult? Maybe they don't believe that they're in a cult, but their religious beliefs are congruent with the members of the organization, but incongruent widely with recognized religious beliefs. How do you approach this? There's questions about family work and couples work, just a lot of those types of themes coming up.
I think that would, incorporate a lot of motivational interviewing, stages of change, and a lot of cost benefit exploration and values up front to kind of break it down and see where they're at. Are there, reasons that being in this cult or organization are serving them? And then in what ways does it not? In what ways could their life look different if they were to engage in some behavioral experiments and attempt some exposures to disconfirm beliefs? So I think a lot of it might come down to personal motivations for change. We may not see a lot of these people in our offices wanting to do ERP, but those are some starting points if someone is kind of ambivalent or having those thoughts.
Thank you. Well, as we start to wrap up today, I do want to say we're not going to get to everybody's questions. And so if you would like your question answered, please send us an email at webinars@rogersbh.org and we will follow up with you. Again, we will have this program published on Rogers YouTube channel for you to view in the next couple of days as well. And you may also access the recording on our resources tab of our website. So it'll be available to you in the future as well. Before we conclude, I would like to share a couple more resources with the participants today. Perfect. And so this will all be included after the program today. You will have the slides as well as the resources sent to you on your personal CE-Go dashboard. And you will receive a link in the next 30 minutes with a link to that dashboard. You can complete your evaluation there. If you participated the entire time, that is you'll do your evaluation and you can download your CE certificate at any time. And if you have any questions about that follow-up email for support at ce-go.com, you can send an email if you have any questions about obtaining the slides or any questions about your CE certificate. And I would like to say our community relations liaisons are anxious to connect with you and to see how we can help support your patients and your network. So please feel free to reach out to us if you would like to learn more about Rogers programs. We thank you so much for your time today, and we hope to see you all soon. Have a wonderful day.